Thank you, everybody. So I'm starting. I have it ready. I'm just sharing. I'm just trying to share only the presentation. So okay, thank you, everybody. So my presentation. Sorry, here we are. Here we are. Hello. So this presentation will I will give some examples of how we work right now in a neuromodulation unit where I work, especially some cases about personalized treatment in TMS and especially RTMS. Thank you, Vitor, for presenting me. So I'm currently attending in a specific unit in Strasbourg that is a research unit, quite innovative, that works with neuromodulation, new treatments like esketamine, brain imaging. We also have a research MRI that enables us to also work on TMS at a better level, because we can work with neuronavigation based on functional imaging. Our unit has a focus on resistant depression, schizophrenia, and old age psychiatry since last year, knowing that resistant depression is very frequently an issue in old age psychiatry. So our patients were already quite old before. I'm going to start really quickly with the clinical cases because I think it's going to be a bit more interactive and interesting. This is a specific case that we observed 2 years ago. It's a 72-year-old patient. The subject of our unit make it easier for me to find older patients. So those situations will be a little more complex and mostly about old patients, because neuromodulation enables us to treat them without going too far into potentially inappropriate prescribing and avoid polymedication. So this is a patient who had a progressive primary aphasia diagnosed in 2015. Mostly at the semantic level. He was already blocked in his everyday life, lowering greatly his activities every day, not going out from home, having difficulties understanding also what was going on around him. So when we saw him, we observed that he was feeling persecuted, a huge amount of anxiety, and all of this seemed to us that it was extremely linked to his aphasia more than something that had to be treated primarily only with psychiatric treatments. So we decided to combine treatment for aphasia and the mood aspect. We enjoyed having a research MRI, and also we did functional MRI to target specific areas of the brain. Thanks to those, we initiated a 90-session protocol with a dedicated robot. I'm going to talk a little bit about it. What you see on the image is the robot that we use to treat patients. So you can see on the left our usual TMS device with the coil that is in a different machine. You can follow here the different installations. And so the coil of the machine will be moved through a robot, which is programmed to follow the head of the patient, depending on a protocol we programmed previously using the functional MRI. So we have a device that enables us to follow the movement of the head of the patient. So if the patient moves, the TMS is still done at the proper place. And it enables us to do way more complex protocols, because if you need someone to move the coil every time you need to change your target, every time you need to change it in a complex protocol, you really need to have a great workout and a great precision. And we tried it with humans, and it's way less efficient. So here is our robot. We did 19 sessions within a protocol that depended on his brain imaging, with a protocol that was initially excitatory for 1 week. He had 2 week rest, and then we had another protocol knowing that there were multiple stimulations on some aspect of the protocol. Here are some details, because otherwise it's a bit obscure. Here you see a modelization of the brain of the patient with the target that we chose, and also a place also where we check for there are the targets in yellow and blue, and but you also have marks for us to know exactly where we are. So we chose those targets to first do an excitatory protocol. So an excitatory protocol means that you go higher in intensity. Here we used a quadrupulse simulation, meaning that there are 4 pulses, a pause, and then 4 pulses again. So here we had this protocol quite high, with 150 pulses a day. It was actually 12 minutes and a half a day, but it was quite intensive for the patient during this time. It was applied successively to 4 sites, distributed anteroposteriorly, and for each site, and depending on the MRI that we had done. Then we proceeded in we had the 2 weeks break, and then we proceeded to do the inhibitory low frequency stimulation, which was a little less challenging for the patient on the contralateral side of the brain. The idea here was to inhibit and excitate, depending on also the locations that showed and explained to us the aphasia. We wanted to try to check if we could lower some symptoms with this. At the beginning, I'm going to have a little spoiler, it wasn't that good at the very first tries. We did Bayesian analysis with the help of a statistician on this, to check if we had an effect thanks to the TMS on the patient. And to be honest, at first, it wasn't that convincing. So to check if you have an effect, you check if your Bayesian factor is inferior to 1, which checks the hypothesis that TMS had an effect. So as you can see, it had an effect on autonomy. Here it's mostly language tests that we did. We did also mood tests, comportamental behavioral tests, but the autonomy was what was improved from the beginning. Our analysis of this was that actually the patient had to come to the center every day to do the protocol, and that gave him the feeling that he was initiating things again. So we didn't think that this was meaningful in the context. But then we had the follow-up visit, and this visit really showed better results. And especially, here is the verbatim from the follow-up consultation. So I'm going to try to read it to you with the rhythm that the patient had. It's extremely hard in France to show videos from patients, even if it's anonymized. It's very strict. It's very strict legally. So I thought this was the way for you to get the best feedback. So it starts slowly. It starts to develop again, because when I read something automatically, there are little thoughts that start to develop, whereas before there was nothing. So he can speak, this patient in this first consultation can speak spontaneously. Those first 10 sentences were spontaneous. I didn't understand what I was reading, and I was unable to highlight anything. So now I know what it's about. This is new, it's all new. His wife also was explaining that he was able to have to elaborate. He was someone who was very religious, and he was participating in working groups with other people reading religious texts that were quite complex also. And he started doing that again after the stimulation. It was amazing what I did at first. I thought, why are they banging me on the head to sign off things by saying it'll get better? It was extremely interesting for us to have this feedback, to know that during the TMS, he wasn't actually fully understanding what was going on. He told us that we seemed to be nice, we seemed welcoming, so he followed it, but didn't understand at all what we were doing at that moment, even though it had been he had accepted. We had checked with him if there was no contraindication. He went through the whole process, not really fully understanding. And then he was able to explain what was happening, what had happened to him, and how he thought about it evolved. I didn't feel anything, and it didn't do anything to me. But attention, many days later, it starts to develop. So that's it. You have to be positive. That's very good. I'm happy. Mood is very good because something is developing. That is good. You can check that the vocabulary for the level he had, he was somebody who was able to elaborate really greatly, but this he was unable to do at the beginning of the stimulation. And we saw that without treatment, without treatment, psychiatric treatment in parallel, he was able to get there, to this improvement. Because before, nothing concrete was developing because my head was completely screwed, but now it opens up more, so I'm happy. I am more active, I read more. Already in the last week of the evaluation, something had moved with fluctuations. And his wife confirmed that she had felt a difference in what he was able to start for conversations, understanding what was happening around him. So we see here that this had an interesting effect on the patient. Those are extremely interesting path. Unfortunately, and that's where we need still to improve, these patients, he didn't maintain this improvement. The protocol didn't integrate, it integrated this induction that I showed. It didn't integrate maintenance with stimulations regularly. And this is what we need to, and this in those examples is what we need to improve. He had some TDCS, so transcranial continuous stimulation, electrical stimulation, and it didn't enable him to maintain this improvement in his everyday life. The question is also, should we have added a treatment to enhance and improve the results of this? So here is, for example, a research case that we had in our unit about neuromodulation. That's the first one. I'm going to the next one. Do not hesitate in case you have anything anything to ask. So the second case is maybe a little more classical, something that we see more as psychiatrists, more than old age psychiatrists. So here is a patient who was 68 years old. He had his first depression, no depression before. We had the possibility to explore with his relatives. He had been living in the area for a long time, so we knew that there was no medical file in any hospitals. His file was clear. There had never been depression, but for 1 year it started with a constant feel of unease, and a discomfort, a mental discomfort, then a clinophilia, anhedonia, anorexia, and then suicidal thoughts and anxiety that were staying the whole day. He was at first taken care of by psychiatrists in a private practice. He wasn't taken care of at the hospital. He started with multiple antidepressants, and at the end, a slightly stronger one. He had venlafaxine, paroxetine, sertraline, mirtazapine, which is a very classic one in old age psychiatry. And seeing that it wasn't working at all, it had been decided that he would have clomipramine 100 milligrams a day, but wasn't wasn't having an improvement that showed this much. It was starting to worry his psychiatrist, who decided to refer him to our unit for resistant depression, thinking that maybe this needed specific treatments. And usually that's the way it works in our area. When you need some specific treatments, you have to go through our team, even for electroconvulsive therapy, so ECT. So this is something we do also. But for this patient, it was too long. It was way too long. And I don't know if you ever experienced this, but when you have a patient who's older, who starts to have depression for the first time, the first thing that people think is also dementia. So the anesthesiologists weren't putting him necessarily in the patients with priority to get the ECT, because they expected that he wouldn't improve as much as the other patients. And the psychiatrists who did the ECT, some of them were also reluctant to take this patient in priority. He wasn't the most severe one also. So we decided to wait for the ECT to try having a treatment with TMS here again. So, sorry. Yeah. So we did our test, but we added some neuropsychological tests, because we are used to having intrication, close connections between depression and maybe the beginning of neurodegenerative disorder. So here, that's what we expected. From the clinical examination, we had doubt. There was no treatment that was supposed to give the motor symptoms that we were seeing. So we were expecting something that was prodromal to neurodegenerative disorder, which frequently makes it harder to treat. So we did neuropsychological tests that showed that there was a neuropsychological profile that was compatible with atypical Parkinson's type. With an inaugural depression. We also have in Strasbourg a center that focuses on Lewy body dementia, Lewy body disorder, and we frequently work with them for patients who have inaugural who at first show a mood disorder, depression, or a more complex mood disorder. So with this patient, we understood that we were probably in this field thanks to the tests. We did an MRI that showed also some aspects of vascular events, and in every territory, which makes sometimes the answer to treatments harder to anticipate, and sometimes harder to treat. So we did a SPECT perfusion imaging to check if there was specific areas that were more interesting, or if we were going for more usual protocols. So we did the stimulation on the left dorsolateral prefrontal cortex. This area of the brain is the one that is the most frequently studied in TMS. It showed good results for depression and is frequently used in many protocols. So here I tried to choose some templates for you to check the different protocols that exist, because we have multiple things that can be used. So we used for him an F3 protocol in the first week initially. It was supposed to be more than 1 week. But we noticed that he was a little too, we noticed that maybe he was a little too anxious. And in our unit, what we are used to do is that the F3 protocol, we noticed that sometimes if patients have any ground for a mood disorder or start decompensating with anxiety, usually we go to another protocol. So here he had a different protocol. So the F3 and F4 are actually targets. You can see it under. I don't know if it's. I hope it shows properly on your screen because I think on my I changed screens for this and I'm checking that the contrast is not maybe the best. Under here, you see a head with different targets that we can have, and you see the F3 and F4. Usually, when you do a TMS without neuronavigation, frequently what is said is that you go to the top of the head here, you move from a few centimeters and you move again a few centimeters, but this is not the most, this is for example, well, that's how you check those are some things that we check when we do the TMS. But here, usually those areas we notice better results when those areas we try to have more precise location. We try to have neuronavigation. We try to have a more precise target, even though we know those targets work. So here under you can see the different targets existing, F3 and F4 being very used in depression in our center. So he had F3, but in so I'm just going to I'm just going to the template. So ITBS means that you are going to have intermittent theta burst. So you have different ways to stimulate the patient. Here we went a little more classic than the first case. The first case is a little more rare, but this case is a little more classic. You have different ways of stimulating a patient. You can just try to have a single pulse. It won't have a long-term effect. That's how you check for your motor threshold, for example, but this won't affect on the long run. Then you have the inhibitory stimulation, where you have stimulation at a regular pace. Then you have the excitatory one, which is more frequent. Then you have the continuous theta burst. Here you see an example of the timeline when you do this type of stimulation. And then there's the intermittent one that is excitatory. So here we tried, we changed a little our protocol, and we tried intermittent theta burst on F3 and continuous one on F4. Here the idea was to inhibit more than to excitate because of the symptoms the patient showed at first. Then we had maintenance with both F3 and F4 every 2 weeks. That was maintained. And the results here was that after 2 weeks, we had a clinical improvement. So we use a lot in our unit the QIDS instead of the Montgomery, the MADRS, because we noticed that in old patients with Lewy body dementia, there was an other type of depression, old age depression. We had more frequently anergia, so apathy. And we feel like the QIDS showed this aspect a little bit more. So that's why we use this one here. So the QIDS went from 57 to 19 at the end of the induction. And this patient had a maintenance for quite a long time, and he is still coming to our unit frequently to have this maintenance. And one of the doctors of the unit sees him each time to check how he is going. We were able to do a maintenance that with longer delay between the stimulations, and now he's actually completely recovered on the mood side of his disorder. And we were able also to decrease the clomipramine and recently stop it completely without a relapse, without a patient who was depressed again, which was for us extremely important, because if you need clomipramine on the long run in an elderly patient, with vascular aspects also on the MRI, I think you guessed that he wasn't in the best shape for on the cardiovascular side. So not having to maintain clomipramine means that you maintain also a good, you lower the risk of side effects with your treatments in an extremely comfortable way when it works. So here is another example. And I'm going with finally a female patient, a very young one for us, 55-year-old. So here is an example of TMS for depression in bipolar disorder. So she was a patient who also had complex psychotrauma during childhood, which was something that had at first, I'm sorry, but at first prevented the diagnosis of bipolar disorder to show, because she was depressed during the winter frequently, her adult life. She started to take antidepressants with her general practitioner during the winter, but having a good relationship with him, him knowing her well, he thought that's her past traumas that come back. I'm sorry, that come back, and that's why she needs it. But maybe I don't need to have a psychiatrist going and coming for more diagnosis or precisions. I'm extremely sorry. It's allergies are starting in France, and it's kicking. Sorry. So, but in 2020, this patient for the first time showed no improvement of her mood during spring. So that's when the first psychiatrists arrived in taking care of her. So the first hospitalizations were even needed quickly. She didn't improve at all and needed her first hospitalization. Plus, she also had her first hypomanic episode. So that's the moment where even if you had doubts, you had to be sure that there was a bipolar disorder. The bipolar disorder wasn't, we didn't know exactly. We didn't know exactly in her family what were the psychiatrical, if there were any psychiatrical diagnosis in her family, because she didn't have any contacts with them. But that was kind of the the way that led us to diagnosis of bipolar disorder. Obviously, we introduced some robust and validated treatments, so lithium and lamotrigine in her case. I'm sorry, to potentialize the lithium and try to have more mood regulation. She improves, but there were still depressive symptoms remaining. She was still not back to her everyday life, to her activities. And when we checked, she wasn't, she didn't show, she never had hypomanic episodes in her adult life where the relatives we knew could observe her. But there she was really not going back to her level of activity that she used to have, and her level of, her previous level of activity wasn't pathological, according to our feedback, sorry. So for her, we did F4. This time we immediately went to this target. Why? Because even though we had introduced mood regulators with the lithium and lamotrigine, we didn't want to have an excitatory stimulation first because we always fear for the patient to turn to an hypomanic phase, knowing that we already had this situation with F3 in the unit. So we decided to start with F4 and then continue with F3, and noticing that she was improved, she had a maintenance with F3 that she could handle. It was also something that we weren't sure about at first. And now, and here you see how this made the case more simple. We have a maintenance, and right now she had 75 sessions total. So she had a long time maintenance, and she is still going very well. She had no relapse, no limitations in her everyday life. We also did a neuropsychological battery of tests. We also did, we really checked thoroughly for any neurodegenerative prodromal disorder, because we really wanted to check if that wasn't involved, and we have no sign of it yet. She had no hospitalization. She just missed her last appointment, unfortunately, because she fell from a horse. Absolutely not in a hypomanic context, but on holiday. So even though she has slight stress factors in her everyday life, she's getting better. It is to note that this patient during this process wasn't ready for psychotherapy for her complex trauma. She wasn't ready at all. And part of the interesting side of TMS is that she was able to stabilize her mood and also follow those aspects of treatments that we can need in patients, that we need to care for our patients. So this was also something that worked really well. So here were 3 cases where we used TMS in our unit. Also TDCS for the first patient. We had tried to maintain the effect with it. We do also ECT, but this is way more known. We don't have yet a lot of ultrasound devices in France, so here we don't practice this, but here are some examples. So do not hesitate if you have any question. I hope I didn't rush it. If you want other examples, I have some cases gathered, other cases that we can chat about. But to be honest, I was afraid that I wouldn't have time to talk about too many patients. And to be completely transparent, I also selected the ones where we had good results. So if you want to ask about our patients where we didn't have so much success, do not hesitate, because the F3, F4 stimulation is something where we had, well, choosing one or the other is something that can lead to have a different response. So we had some patients going to hypomanic phase. So this is something that we have to know. But yeah, we also have some results that are not completely that are not completed. We have some studies about Lewy body dementia also, where I think the TMS is extremely interesting to manage both neurological and psychiatrical aspects, and also knowing that patients will have many medications. It enables us to really focus on the treatments that are needed in terms of pharmacology, medication, and it avoids a lot of complications for those treatments, especially in old patients. I also focused on the patients that we have, so sorry if the examples are a little more older than the average patients.
Thank you, Ilya. So it was a really interesting presentation and 3 very interesting cases. Maybe we'll set some time for questions, or some discussion if anyone wants to ask something.
Maybe, Victor, I can break the ice.
Yeah.
Okay, first of all, thank you for this very nice clinical presentation. And I really appreciate it. Also your honesty. I say I present 3 cases, but I enjoy especially the clinical approach that you are showing to us, because one of the problems for me is in TMS is that we are going probably to a standardization of a treatment. And I think that would be really a problem. But I'm pleased to know that in your center, you are already using kind of custom-oriented or personalized treatment, even if it's not just personalized on base of a neurofunctional data, but also based on clinical data. So I really appreciated this effort not to stay clinical while you're using some technology, because there is a gap between. And I have a lot of questions. I wrote down a lot of things where you was doing the presentation, starting from the last one that is going very well. I was wondering, how often do you offer follow-up session to this patient, and what's the basis for define the length of time of a post session?
So we used the same approach to the one that we have sometimes in ECT. So at first it was 2 weeks delay. Then we saw that it was really going well. And we saw that the patient was also not too anxious at the idea of making those stimulations less frequent. So we followed the patient's anxiety and comfort with that idea. And also the fact that we were really, well, we waited for a few months before having her come a little less frequently. And then we went to 3 weeks, but very quickly to 1 month. And to be honest, completely, right now we are trying to stop the stimulations, but it's been too recent for me to tell you that it's miraculous and it works. So we were able to add delay between stimulations, but it was very progressive. And also we really, well, we are extremely lucky to be a research unit, because I think when patients come, they are resistant to their treatment, but also they are used to I'm guessing that is in most countries now to a health system that doesn't necessarily have the time to really check everything. And in our unit, we are supposed to take a long time for each patient, because we know that if they come to us, it means that it's not simple. So we have to take time. So we really care about checking if they are not too anxious, if they are really understanding understanding and accepting the treatment as much as they can. So we really worked with her to check also of how she was feeling, and we did a lot of psychoeducation, so she would immediately notice the signs that a relapse was coming, which she never had before, because she had depressive symptoms during winter, and then immediately many hospitalizations, but without being in a state where she could have psychoeducation properly. So it was a mix between checking for the patient and trying to distance.
Yeah. One other question is about this was a bipolar depression, or a mixed episode. So there is an open issue: is dorsolateral prefrontal right on left, or low frequency on the right side. How do you decide, and what protocol do you decide this patient?
So I'm going back to maybe I'm going back to the templates, so it's easier to follow with view on it. So how we choose. So there is really this idea that we are going for the most inhibitory protocol always at first. And also there's this idea that in case we have a patient who is really depressed and we want to maybe to be active a little faster, maybe we will take a risk. But the thing is, when you have TMS in a unit, it means that you have doctors in the unit. I don't know how it is in every country, but in France, you cannot have TMS without a doctor.
Yeah, we have a doctor.
Yeah. So this normally the person who is on call for in the building plus on call at any minute for the nurses of the TMS, they make themselves available to check for the patient. So in case we noted that we have a patient who has a QIDS that is too high with a bipolar disorder, we might go for an F3 still, a more excitatory protocol. But in that case, we check for the patients almost every day. So that's how we choose. We choose on the severity, on if that person has a bipolar disorder. We always take patients who have regulatory treatments to regulate the mood, obviously, and for a long time enough, and if they take it properly, etc. But also sometimes it also depends on the target we have on the functional MRI. To be honest, I didn't show the most exotic things we're doing because they are mostly in psychotic disorders with psychomotor symptoms and hallucinations. But for some patients, we use a specific classification for endogenous psychosis called Wernicke-Kleist-Leonard in our unit. And sometimes what will be a bipolar disorder in the DSM-5 will be for us endogenous psychosis with sometimes psychomotor symptoms at the first at first glance that will look like a bipolar disorder, but where actually the psychomotor symptoms seem to be more of endogenous psychosis. This classification is very precise. It's a little complicated to explain it in less than something like 10 hours. But for some clinical descriptions of this classification, for some phenotypes, we have actually a biomarker on the functional MRI. And in this case, that's the target we're having. And when we have this clinical diagnosis and we have a compatible functional MRI, we are going for to target that specific areas that we identified. So it's a little bit more complex practically. We are sometimes, to be honest, a little scary when we ask patients to file questionnaires to know exactly the type of IDs they have, the type of thought disorder they have. We are really thorough on this because we noticed that it improves greatly the results. This classification, if you're interested, is called Wernicke-Kleist-Leonard. It's a German classification, an old school one, but
no, I know very well that because we have an Italian translation that was published in the 80s, but also I'm a good friend of Werner Strick. Maybe you know his name. He was in Florence for a while, so I mean, I know that is a little outdated now, the Kleist-Leonard classification, but still find very helpful. So I know very well that what are you talking about? Yeah.
Okay, thank you. Because I know it's not necessarily very well known everywhere, but the most interesting part of this classification is also that it forces you to be clinically very thorough on your diagnosis and not just to be honest, we we don't just say, hey, she had the depression every winter, etc. She has a bipolar disorder. We really check for psychomotor examination for any sign of catatonia. We check for also how the person elaborates with thoughts. So we do neuropsychological tests, but we also do some text on abstract thinking to check if there are things that are coming in the way of, that are not just a simple mood disorder. So yeah.
Well, thank you so much. No, you remind me the old time, because we really it was translated in by Feltrinelli, the end of the 70s. So, but now I'm sure. Thank you for reminding to everybody, because I don't think that most of the younger researchers know this classification, but it was it was amazing at that time for Karl Leonard being so precise in the description of fine movement and fine also thought disorders, that now we are far away to be so focused on that aspect. But when you talk about giving a clinical definition of a subject, you need to follow that kind of approach. And I really thank you for bringing up this approach today. But I think I let room for other questions. I guess there are other people asking. Otherwise, I have other questions.
Problem.
Yeah. So just following the stream of clinical approach, above the second case that you present, now that you were talking about some white matter vascular lesion, and I was wondering if you usually we found this in several vascular problems, but also there are some specific kind of rare disease like CARASIL, and other little vessel white matter encephalopathy. I was wondering if you, in this patient, following your clinical approach, if you also have done a study of homocysteine, folate, and inflammatory panel in this subject, because TMS has a strong anti-inflammatory activity, but it's good to check the inflammation, also the level of absorption of folic acid and other substances that can be very important in the process of improving the plasticity of the brain. Are you following this kind of a global approach to this patient?
So we are very lucky to have a team that is very specialized on atypical Parkinson syndromes. And so, for example, folic acid is always in our biological tests when patients arrived, because we noticed that it had a massive impact on the patient. Also, at a very basic level, thyroid hormones, that's so important. And we noted that sometimes resistant depression is just one of those elements that was missed, that explains why it is resistant. So we check for this. We also sometimes check for in some patients to check if it's more endogenous depression. We sometimes also check for we also sometimes do tests on the hormones, on the the hypothalamus cortical path, to check if there's nothing, if it tends to be more endogenous or not. So we do a TRH test. I'm afraid that I'm not translating it properly, but we check for the cortisol and those things sometimes in tests where we take the patient in our unit for the full day to do those checkups. Those are the tests we are doing. We also, we check for also In this situation, we also had lumbar puncture to check also for markers for dementia, but also to check other aspects. We're always afraid, especially in elderly patients, to miss a situation where it was pseudo dementia, but actually an encephalitis, because that happens, especially when you work in a resistant depression center. It's we felt like we have a tendency to select more patients than another unit. So these are the things we check. But on the inflammatory side, we also check for any event that could happen. But those are the things that we check for.
Okay, yeah, because in this case I would check the C-reactive protein and also the homocysteine, because it might be one case where you might find some reason of resistance. Of course, this patient was treated with chloromethrin, that is probably the most anti-inflammatory in the numbers of antidepressants we have so far, or maybe not as much as fluvoxamine, but it was not used in this case. But I was wondering if you considering the anti-inflammatory effect of the other treatment that you are doing this patient, because I think that is something that you have to take in consideration to improve as much as you can the effect of the TMS in this patient.
Yeah, well, this case, to be honest, we are, I hope it was clear, but we are fully aware that the clomipramine worked with the TMS, and that the TMS just enabled to get rid of the clomipramine later. But clearly, the fact of having this treatment was a significant improvement before the TMS comes and helps treat symptoms. Yeah.
Yeah, no, just to tell you that sometimes our treatment works not because of their neurotransmitter activity, but for their anti-inflammatory activity. So it's important to consider this aspect. So, but I want to let room to other questions, otherwise. Is anyone in the audience that want to ask you something?
If no one asks a question, I actually have one for Dr. Ilia. So throughout the presentation, we can see that the neuromodulation techniques hold promise in alleviating various symptoms in various psychiatric conditions. So we talked about depression, bipolar disorder, the degenerative disorders. And I was wondering, building on that discussion, which disorder do you think could benefit the most from neuromodulation treatments? And if there are specific mechanisms or neural circuits that might be targeted to optimize therapeutic outcomes.
So
thank you.
The most validated indication is depression, and even in bipolar disorder, it's mostly the depressive side that is treated by TMS. We also have hallucinations that are really well treated in some cases by TMS. And that's why it's interesting to have the whole package with the functional MRI and the not just doing, choosing a target. You have those protocols for depression where you just first mark where the patient should be stimulated, and you put a kind of a hat on his head and you just stimulate that area. That's not that precise, and I think that we can treat more things if we get more precise. Of course, there's the limits of TMS not going as deep as some other neuromodulation techniques, but the other things, so hallucinations is a very interesting aspect also. I didn't go to our situations because it's very quickly linked to our use of some classifications, and it's a little more technical, and I was afraid to lose not to be clear enough. But hallucinations is a good indication. Pain is an extremely good indication. In our center, we also have some patients that are taken care of for neuropathic pain. So this is an extremely interesting way of treating them. So with an inhibition of the areas that are problematic, and this works really well in some patients when medications fail to really help, and also when you have a risk of addiction, of sedation. So that's an extremely interesting also target. There are other fields where research on TMS is also interesting. You have tinnitus. We had some patients in our unit who are taking care for tinnitus. We have the impression that some of them also have depression. So when that happens, we target depression also. And we have the feeling that sometimes the improvement comes from the treatment of depression more than from the treatment of tinnitus, because the targets that exist for tinnitus are not as efficient. It doesn't work. It's not as validated at all as depression. So those are the aspects. And also I was mentioning it when on the brain imaging, we have an area that is where we see that we could inhibit or have an excitatory effect on it. And it's linked because of where it is to the symptoms of the patient. Sometimes we try. So that's how we had some effects on some types of chronic catatonia, of catatonic psychosis. So here is another thing, but this worked for very precise clinical situations. There are also studies on, I know that there are also studies on brain injury, on traumatic brain injury, where they are starting to check if having TMS during recovery at some points cannot help improve the recovery. But in my memory, the last time I checked the articles was last year. Maybe some things got improved, but it wasn't clear in the last articles exactly how to predict when the TMS will be efficient in the recovery. So they noticed that sometimes it was, but it was hard to predict in the articles that I saw. So here are some fields where we use it. I hope I'm not forgetting.
I think maybe you forget one, because of the OCD.
Yes.
Yeah, I really care about OCD now, but because there are already FDA approved with a deep TMS, but also we have a large experience that we've been publishing papers showing that there are several targets for OCD and OCD spectrum. And more recently, we published paper about gambling and substance treated with TMS. So there is also the field of compulsive disorders and addictive disorder that really benefit a lot of TMS, and not with just one protocol, but there are several different targets in this condition. Maybe you can mention some of them.
Yeah, to be honest, I have colleagues in my center who take care of patients with OCD, but I have never had, I mostly focus on old patients. And fortunately, I don't have any patients.
Because what is interesting OCD is that, you know, the protocol that has been approved from FDA that was published by the group where Professor Zoa belonged to, Professor Zhang and the other, has introduced a very interesting dimension of the treatment, that is the active patient. So the patient during the session is involved in mental exercise, evoking of symptoms at a level that they can deal, and arousing the circuit that are targeted by the TMS. So I think this is a model that is extremely interesting, because involve the patient as an active part of the treatment and involve a psychological treatment during the session. So I think that, and it's the same that we are doing for gambling, where we arouse the circuit with an image and evoke, triggering this image, during the session, and the same with suspense. So the importance of having this interactive protocol is extremely update, and is something that really give you a how do you say, a picture of TMS as something that is part of a global approach where you, of course, you have to consider all the medical features, but also you have to establish a therapeutic and psychological relationship with the patient, and ask the patient to be involved in the treatment, because the triggering list of events has been have to be built based on the experience of each single patient. So this is something that really, I mean, also give a good image of TMS, because someone image the TMS is a kind of neurosurgery. Now you work on the, but it's not. You need a patient that is active part of the treatment. And in the OCD, has been well documented. So
thank you for this. It's really interesting.
I don't know if we have any more time for questions, but if no one steps up, I have, if I may, just one question for Professor Stefano, which is regarding the future of this treatment. So considering the complexities in adopting new technologies and treatment modalities, Professor, what barriers do you foresee in the adoption of neuromodulation techniques across various clinical settings? So how can these barriers be effectively addressed to facilitate the integration of neuromodulation therapies into routine clinical practice?
Thank you for asking. I mean, the main problem in my country, but also in other country, we are working on asking for reimbursement in France. I co-author one paper that was published about this issue in France, is the cost effectiveness of the treatment. Of course, there are studies showing that in terms of cost effectiveness, TMS could be a good resource, but most of the study are not good enough to get all the economical advantage of treating resistant patient and through remission and I will say to recovery. So the first issue is how to educate policymakers to the assessment of a cost effectiveness of neuromodulation, because this is the greatest barrier to the enlargement of the use of TMS in the clinical field. And we have to support this position, offering more scientific evidence about cost effectiveness of TMS. Then the future, we have seen already something about the future, because our colleague has shown the robot that is targeting the, because we can improve how in several different ways. One is a better, more precise targeting, and more precise targeting during the session. So a robot arm, like we show that during the session, can get the functional connectivity. And we are in contact with our colleague Aalto in Finland. They are working on a robot that can give you at once EEG functional connectivity during the session, and following the target in case the patient head is moving around. So I think that would be a great improvement. Okay, let's see. And so I think that is another targeting. I mean, personalized targeting. There are several ways. In Palo Alto, they are studying a targeting based on crosstalk between different areas of the brain, of broadband 25 and the broadband 46 of a crosstalk. So targeting can be, cost is one issue. Targeting is another issue. That one that I introduced, what the patient activity during the session is another issue that can be improved further. And I think that is very important, because what we are doing anyhow is to offer to a patient a possibility to make a different experience about his mental activity and his disorders. So it's something that have to be expressed somehow from the patient and have to be part of a mutual agreement between the doctor and the patient. It's not something that we are doing on the patient. It's something that have to be evolve in a kind of interpersonal spaces between the patient and the doctor. And so I think then, we don't know enough about the combination with other treatment. There are not so many studies about the effect, the differences, let's say, between in terms of electric activity and connectivity between lithium and lamotrigine, let's say, something that we've seen today, and TMS and specific protocol with TMS, because we have been studying what are the area where the lithium works in the brain, and what are the area where SSRI works in the brain. Let's say most of SSRI doesn't have a strong activity in the pre-motoric area. So maybe that is a good way to combine. You can work on the premotoric area because the SSRI not working enough. Lithium is working mostly on the broadband 11, broadband 12. So you can consider that if you are treating the patient with lithium, that area is already treated, but some other part of the frontal lobe are not treated with lithium. So we have to work considering where we are acting in the brain of the patient, where we are acting when we are prescribing medication, where we are acting when we use TMS, what we are doing, and where we are working in the brain of a patient, where we are talking to the patient. What are the areas that are involved in psychotherapy? Different psychotherapy act in different parts of the brain. So, I mean, it's really a new area, because introducing the TMS, you say that is a new treatment. But TMS is, of course, a new treatment to be had. But if you consider only that, you will lose the most important part that is going to change completely the field of clinical neuroscience, because TMS is a way, is an investigational tools to investigate the connectivity in the brain, and is redrawing completely the architecture of the connectivity in the brain of the patient. So we have to use all this information, and we have to adopt a brain-centered point of view on the treatment. So when we talk about how to integrate different treatment, now we talk about like CBT plus pharmacotherapy. But we are talking about a integration that's happened in the clinical setting. Now, instead, with TMS, exploring the brain during the session, or exploring how the different other agents we use for the treatment are working in the brain, we can figure how our intervention interact in the brain, not in the clinical setting, but in the brain. So what I'm touching now when I'm prescribing, this treatment, and what I'm doing, and not only in terms of neurotransmitter or connectivity, but also in terms of inflammation, because we have now this model of low-grade inflammation. TMS, neuromodulation, is an anti-inflammatory effect, and our medication also have an anti-inflammatory effect. So we had to understand why, you know, in this patient, fluorimycramine works is because of its strong anti-inflammatory activity, where has been more effective in terms of reduction of inflammation. Because if we can reduce inflammation, we can improve neuroplasticity. So we have to start to make a different reasoning, not just clinical, but really circuit-based and on model that involve inflammation, plasticity. So it's a new approach. It's a, you know, it's not just a clinical psychiatry, it's a clinical neuroscience that involve neuroimmunology, involve neuroanatomy, involve electrophysiology. So, and this is a good deal of study that you have to do for for your career. So this is the future, and you are the future. So you have to get all this stuff that is offering to you.
Thank you, Professor. So I don't know if we have time for more questions. If not, I don't know, Dr. Ilya, Professor Pallanti, I don't know if we should end the session. What do you think?
Oh, I feel so. I mean, I'm pleased. I want to thank you for having me today, and I was very pleased to listen to the presentation, to be part of this initiative. I wish we can follow up and have other good meeting, because as I told you, this is just a start point of a new culture in clinical neuroscience. So I mean, there is a lot of room for improvement, a lot of for new things and contribution. And I think young researchers that really they can think out of the box, they can give a more suggestion for future refinement of this technology.
Well, then, if I may, let me just thank you, Professor Pallanti and Dr. Ilya, for your insights and expertise. And as this webinar draws to a close, we thank everyone for your attendance. And a special acknowledgement is due to the International College of Neuropsychopharmacology for the support in making this event possible. Thank you, everyone, once again, and I will see you next time.
Thank you. Bye.